testing. Okay. Okay, testing 1, 2, 3. It says connecting. Is it connecting me again? Okay, so we are live on the web right now? Okay, all right. Well, we're going to enter our conversation at this time.
You said that like a minute ago.
I know.
Oh.
Okay.
I was like, her mouth isn't moving. That's why I was looking at you like that.
Okay. Got it. That's through the YouTube link, or is that through the? Okay. Got it. But YouTube link isn't live yet. No more, because I'm not connected. How she looks on YouTube.
Um,
Good afternoon, everyone. Okay. Okay. She's on. She's on. She's on right now. Yeah. Good afternoon, everyone.
Good afternoon.
Good afternoon.
Good afternoon.
Hi, good afternoon.
Okay, I'm on the Zoom.
Good afternoon.
Yeah.
Hello.
Hello.
Hello, Tina Granger from Essex University.
It's so awesome watching everybody connect from the multi-screen. So we're going to start in about 4 minutes. So if you all could just mute your phones for us for now, and we'll get started momentarily. Thank you all so much. He's on. He's on now. Seeing some of the names. Okay. So like. Okay. Thank you. You good? Boy, has everything pulled up for you. Your faces. Huh?
Calling both committees, right? The roll for both committees.
I'm sorry.
I'm calling the roll for both committees.
Yes. So
Okay.
you'll start with the executive, and then
The sub.
the sub,
Okay.
and then whenever I do introduction. Did you want me to reintroduce the exec? They'll be
Yeah.
called in the role, but if you want me to reintroduce, I can.
No, when she calls the
The
roll,
roll.
that's
Okay.
it.
That's it. Okay.
Okay. So we were gonna, there's a section in the script where I was reintroducing, where I was calling out the names and where they represent for the subcommittee members, since we did not
Right.
meet them.
So you're gonna call the roll for everybody,
So
right?
she's
Yes.
calling the roll for everybody.
Okay.
And then I have a section that acknowledges and welcomes the subcommittee members. And I just say, and they are, whoever
need to
from
do-
wherever.
So do we need to do that twice? The roll call and,
Why don't I just call the executive committee and then you introduce the subcommittee?
We can do
Yes.
that.
Yes.
You want to do that?
Yes.
Okay.
so we're not
Since
doing
they
it
not-
twice?
yes.
Yeah.
That
Okay.
makes sense. So
That
after I
sounds
do the
good.
roll call for the executive committee, then you.
Okay. That
Yeah.
sounds good.
Yeah.
That makes sense.
So those numbers that are waiting make me nervous, just because they haven't actually put in who they are.
Where are they? I can take a look at them. How can you see
Well,
it?
Florida is just letting them in, but. Okay. Yeah.
Let me give him.
Okay. Thank you. Good afternoon again, everybody. We're just trying to get settled, and we will start in about 1 minute. Thank you all so much again for being patient and being here with us today. Start in about a minute.
Dr. Brown?
You ready? Okay. Okay, good afternoon. It is so awesome to see everyone's faces and, of course, to be back together again to address this very important cause. I'm Katara Williams. I'm the Chief of Staff for the Southern System, and we will begin officially with a roll call. Ms. Gerald?
Good afternoon. Dr. Sandra Brown,
Here.
Dr. Thomas Levis,
Here.
Senator Regina Barrow, Dr. Earl Benjamin Robinson,
Here.
Dr. Takesha Davis,
Here.
Dr. Rebecca G,
Here.
Dr. Corey Hebert, Reverend Theron Jackson,
Here.
Mr. Raymond Jetson,
Here.
Dr. Peter Kasmarskit,
Here.
Dr. Kathleen Kennedy,
Here.
Mr. Michael McClanahan,
Here.
Dr. Orlando McMeans,
Here.
Representative Dustin Miller,
He is on. Okay.
Miss Judy Morse,
Present.
Dr. Demetrius Porche,
Here.
Dr. Ebony Price Haywood,
Here.
Dr. Ronnie Whitfield,
Here.
Dr. Gary Wiltz.
Here.
Is Senator Barrow on? Dr. Corey Hebert. Dr. Williams.
Okay, thank you so much. Now, that was just the introduction of our executive committee members. But of course, today is our first meeting where we are not only introducing and welcoming our executive committee members, but we're also introducing our subcommittee members. We want to thank you guys, all of you, for agreeing to serve. Again, this is certainly an important cause. Now, before we begin, there are a couple of items that I want to cover. First, we're asking that you phones until it's time for you to speak so that our distractions are limited. Also, if you have any public comments that are germane to this agenda, we have a staffer that's standing by to receive your public comments. So please send us an email at public_comments@sus.edu, or you can call 225-771-4364. So those are the ways that the public who are watching via live stream right now on YouTube, those are the ways that if you would like to submit a public comment that you may be able to do so. Now, as all of you know, the COVID-19 pandemic, of course, continues to impact our state. So the work that we're doing through this task force is going to be critical as we seek to minimize the incidences and spread awareness, especially for our most vulnerable populations. We are, of course, thankful to our leader, our Governor Edwards, for his leadership during this time. And as a task force, we are going to work collectively and remain focused on our goal of ensuring greater access to high quality health care in order to improve health outcomes for the citizens of this state. So I want to now at this time officially welcome for the first time our subcommittee members, who we have a very impressive cadre of leaders who are joining us in this work. So I'd like to maybe just call their names for the sake of time. We're going to call your name and the agency in which you represent. So those subcommittee members are Attorney Delso Alford with the Southern University Law Center. Thank you, welcome. Dr. Damian Ejigiri from Southern University at Baton Rouge.
Present.
Dr. Aaron Van Home from the University of New Orleans. Miss Alma C. Stewart from Louisiana Center for Health Equity. Attorney Christopher Tyson from the LSU Law Center.
Thanks.
Dr. Alicia Bates from the Franciscan Ministries of Our Lady University.
Hello.
Dr. Meg Brown from Grambling State University.
Here.
Dr. Leanne Fowler from LSU Health New Orleans School of Nursing.
Here.
Dr. Tavell Kendall from Loyola University, St. Thomas Community Health Center and HIV Prevention and Treatment Center.
Here.
Miss Cindy Schneider from the Franciscan Ministries of Our Lady University.
Here.
Miss Carol Smith from Optimum Management. Kathleen Tate from Northwestern State University.
Here.
Dr. Janine Thomas with South Louisiana Community College.
Here.
Dr. Christy Anderson from LSU Health Science Center, Lafayette. Dr. Renato Banks from the Baton Rouge General Mayo Clinic Care Network. Dr. Keith Ferdinand from Tulane University.
Here.
Dr. Robert Moffin from Louisiana State University Health Science Center in New Orleans.
Here.
Dr. Connie Arnold, LSU Health Science Center, Shreveport.
Here.
Dr. Terry Davis, LSU Health Science Center, Shreveport.
Here.
Dr. Marguerite Ishivari from Xavier University. Dr. Peter Foss from Dillard University. Dr. Faye Grimsley from Xavier University. Dr. Amy Lesson from Dillard University.
And here.
Dr. Rhonda Reddix from Franciscan Missionaries of Our Lady University.
Here.
Dr. Daniel Sarpong from Xavier University.
Right.
Dr. Lisa Van Hoos from University of Louisiana at Monroe.
Here.
Miss Shalina Davis from Louisiana Public Health Institute.
Here.
Dr. Amanda Dumas from Louisiana Department of Health and Hospitals. Miss Christian Engel from YMCA of the Capital Area.
It's actually Mr., but I'm here.
Mr. Thank you, sir. Welcome. Miss Tina Granger, Nicholls State University.
Here.
Miss Catherine Haywood from Louisiana Community Health Workers Outreach Network. Mr. Rudy Macklin from Louisiana Department of Health Hospitals.
Here.
Miss Tiffany Netters from 504 Health Net Incorporated.
Here.
Miss Erica Rogers with the Brave Heart Foundation.
Here.
Dr. Derek Riveras from Louisiana State University.
Here.
Mr. Frederick Thomas with the National Organization of Black Law Enforcement Executives.
Present.
Dr. Ziad Ashkar from Louisiana Lafayette.
Here.
Dr. Jacqueline Harris from Grambling State University.
Here.
And Dr. Simone Rambati from Loyola University. So are there any other persons that are on the call and your name was not called?
Yes.
This is Dr. Corey Abear.
We got you, Senator Rowe. Welcome.
This is Dr. Corey Abear.
Gotcha.
Dr. Renando Banks.
Stewart.
Okay, we got you, Dr. Banks. Dr. Stewart, we got you. Dr. Abear, we got you as well. All right. Anyone else? Okay.
Dr. Williams, this is Courtney Phillips on the call.
Thank you. And that's a perfect
And,
segue into.
Dr. Williams, this is also Adrian Wilson in the governor's office.
I'm sorry, say that name one more time, please.
Yeah, Adrian Wilson in the governor's office.
Dr. Wilson, hey,
Yes,
gotcha.
yes.
All right, gotcha, Dr. Wilson. So what I'd like to do now before we actually dive into this body of work, I want to welcome and officially introduce Dr. Courtney Phillips, as you just heard her a moment ago. She's the new secretary of the Department of Health and Hospital. She's also a graduate of Southern University. And Dr. Phillips, we'd like to welcome you back home. And we are certain that you are certainly hitting the ground running at this time. And if you'd like to make just a couple of comments, brief comments to the group, please do so.
Thank you, Dr. Williams. Well, first, thank you and Senator Barrow for allowing me to join the call and give some brief comments. When the governor created this task force, again, it's definitely a call to action, but not just for the immediate situation that we see in COVID. I think it's a springboard for things that we know that have been existing. We all know that the disparity that we see in COVID just reinforcing long-standing problems that we see, not just related to health, but also with issues for housing, employment, and other things that contribute to the health. So I just wanted to thank each of you for the support to the state's response, as well as the voice from each of your communities that allows us to build that information into our So I look forward to working with you all, but thank you for taking time from your day-to-day work to contribute your efforts and voice to this particular work. So thank you all.
Thank you so much, Dr. Phillips. And of course, you are welcome to be a part of this work. We will need your expertise. And so we are certainly glad that you could join us and be with us today. So we would also like to welcome our co-chairs, Dr. Brown and Dr. Levis, who are here. And we're now actually going to move right along with the agenda and ask them to chime in to go ahead and make a couple of remarks relative to the charge of the committee. Dr. Brown and Dr. Levis.
Good afternoon, everyone, and welcome. Welcome our executive task force members and our subcommittee members. Myself, along with my co-chair, Dr. Levis, are looking forward to working with each of you. And I'd like to give special thanks again for appointing a COVID-19 Health Equities Task Force Committee. He heard our voices, he took action, and he took a bold step in appointing this very important task force. He has given the task force the following charge. If you could show our charge.
No, that's
Not that one.
Yeah, right there.
And we will pull up the charge in a minute.
Madam Co-Chair, while you're pulling that up, this is Senator Barrow. May
Yes,
I take
Senator.
this opportunity to thank Dr. Phillips for joining us today. I look forward to working with her again and to make sure she knows that she has my total support in all of the work and responsibilities that she have over the department. And I just want to thank her once again for her work and look forward to working with her again and thank her for joining us today.
Thank you. Thank you, Senator Barrow, on behalf of the
thank
committee.
you. Yes, thank you.
Okay, so here is the COVID-19 Health Equity Task Force charge. And as you can see here, the charge is to provide recommendations relative to health inequities which are affecting communities that are most impacted by the coronavirus. The task force will examine opportunities which provide greater access to high-quality medical care and improve health outcomes. As you can see, the charge is broad. It's broad enough where the task force has the opportunity to add specificity in setting priorities. Our goals and outcomes, or our deliverables, will be to provide reliable and data-driven information on COVID-19 safety and prevention, provide the medical community with best practices and protocols for treating communities with underlying medical conditions and health disparities, and ensure testing availability and ease of access for all communities. The timeline, the task force is to begin its work immediately and continue as needed. The actions and research will ultimately result in improved health equity in Louisiana, serve as a foundation and resource for addressing healthcare disparities in vulnerable populations, and contribute to the progression and improvement of Louisiana's healthcare rankings. As you are aware, we rank 49th out of 50 as one of the least healthiest states in the United States. And finally, to measure progress, a statewide dashboard on health equity will be created. Dr. Levis, do you wish to add anything to the overview of the charge, goals, or timelines?
No, nothing to add there. Just to, again, thank all of you for your time and willingness to be involved in this important task force.
Thank you. At this time, we have invited Dr. Earl Benjamin Robinson, who is a member of the Executive Task Force from the Louisiana Department of Health, Office of Health Equity, to present some updated data on COVID-19 to the task force as it relates to race. Dr. Benjamin Robinson.
He might be muted. I can't hear.
Okay, sorry guys. I was just running my mouth and didn't know that I was muted. So thank you guys for having me. The data that I'm going to be reviewing today is information that is publicly available on the LDH COVID-19 website, but just going to take a look at some of that data. And I want to thank Dr. Bu and his staff in particular, Dr. Lee Mendoza, and especially Teresa Sukol, who is the Assistant State Epidemiologist and Surveillance Manager. And a lot of the data, or most of the data that we're going to be looking at today is data that she managed today's presentation. And so if you go, when you go put in LDH COVID-19, it will bring you to LDH's page. And this is some of the data that is available there. And this was pulled yesterday. I think there was some updates today as it relates to number of people who are reported. I think there were 700 additional, but just sharing that to say that this information is updated daily. And so these numbers might be slightly different than they were yesterday, but for the most part, this is roughly what it is at the present. We see that African Americans represent 58.28% of those individuals that have died from COVID-19. And we also see that Latinos or Hispanic individuals represent 1.65% of those that have died from COVID-19. Men represent those that died. And when we look at the top three underlying conditions that most affected those resulting in death were hypertension at 55%, diabetes at 34%, and chronic kidney disease at 19.74%. And again, as of yesterday, we reported 28,000 individuals. I believe 700 have been added as of today. And 1,862 individuals have died. And there's just additional information that you can also get at that website. So I just wanted you guys to know that this is what is, when you go to that website, this is what you will initially. And so the data that I'm going to go over the next 5 pages is data related to the death rate by parish. And we're only looking at 13 parishes. And these are the parishes that have deaths of, as relates to COVID-19, of 25 and more. And the reason that has been set as a standard by the state in reviewing death by race is because that's what we're modeling what CDC does, and so that's why we're basically doing what CDC has done in relationship to death rates and race. And so we're going to be looking at 13 parishes, and this PowerPoint will be made available to you. And so if you want additional information, all of this can be at this link. And so in Ascension Parish, we see that 35 people have died in Ascension Parish, and 24 of those individuals are African American. In Caddo Parish, we see that 93 individuals have died, and 68% of those individuals are African Americans. Now you can compare, as I'm saying, the number of deaths in relation to African Americans or Black. You can also look at the populations of African Americans compared to the number of deaths, and also the size of African Americans compared to the number of whites, to see that they're to really, it brings home the disparity. And so in Cattle Parish, of the 93 individuals, 68 of them are African American. In Calcasieu Parish, of the 26 individuals that have died, 16 of them are African American. And East Baton Rouge Parish, of the 107, looking at Iberville Parish, of the 26, 17 are African American Black. In Jefferson Parish, of the 331, 178 are Black African American. Lafourche Parish, of the 39, 20 of them are Black. And in Orleans Parish, succumb to COVID-19, 309 of them are African American Black. St. Charles Parish, 18 African Americans have died compared to the overall 36. In St. John the Baptist Parish, 35 African Americans have died in comparison to the 64. St. Landry's Parish, 6 African Americans have died in comparison to 36 that have died there in all. St. Tammany's Parish, I believe 100 individuals have died, and 24 of those individuals are African American. And in the 13th parish, again, these are the parishes where 25 deaths or more have happened. In Terrebonne Parish, of the 26, 14 are African American. And so in my conversation with both Dr. Mendoza and Teresa, because we chairs had asked some questions about hospitalization data, and Teresa's and Lee's work is centered in OPH data, and so we don't necessarily have access to that data. And so again, most of the data that we are reviewing here it comes from the ID, it comes from the Bureau of Infectious Disease EPI section. And so some additional information, and so that section doesn't have hospital data. Also, something that Dr. Mendoza shared in relationship to us asking about hospitalization is that hospital data is presently limited, not a lot of demographic data available, and race is not necessarily an element of that data. And again, this was just some of the what was shared in my conversation with Dr. Mendoza regarding LDH having access to hospitalization data at the present. And so there was another query that we asked that was sent out, and it was deaths in nursing homes and other adult residential facilities. And it should be noted before I share these that these numbers are reported by individual facilities to the Department of Health. And so COVID-19 cases have been reported by 156 nursing homes and 74 other adult residential facilities. A total of 2,780 COVID-19 cases have been reported among residents of nursing homes, and a total of 361 COVID-19 cases have been reported among residents of other adult residential facilities. A total of 590 COVID-19 deaths have been reported among residents of nursing homes, and 47 COVID-19 deaths have been reported among residents 79 licensed certified nursing homes in the state, and also 157 adult residential care providers in the state. And so at the present, that is the data that I have to share with you. In the future, what will likely be happening is the individuals that manage this data inside LDH we will be asking that they be the ones to report the data out. So that's it. Do I have any? Well, I'll turn it back over to the chairs.
Yeah, let me invite, if there are any questions, to you can submit those questions through chat, or I guess I'm not hosting, but if someone raises their hand using Zoom, a host can unmute you so that you can ask your question. But I'd like to start by just kind of making one inquiry about this. So you referred to the rates in the beginning of the presentation as death rates, but I think it's real that we be very clear that these are not death rates, that we do not have death rates because we don't have a denominator. So a death rate is calculated as deaths divided by the number of people at risk. And since we don't know how many people have been and who has been infected, we don't have a denominator that will allow us to calculate a rate. What we have is the proportion of deaths that are African American, the proportion of deaths that are white, the proportion of deaths that are others. And the reason that that's really a very important thing for us to focus on is that if it's the case that, let's say, 70% of the deaths of the death rate actually is 70% for African Americans, then that suggests something very different than in our response and intervention is going to be very different if what we find out is that because if 70% of the infected people were African American and 70% of the deaths were African American, then that suggests that the issue is on who gets infected. Mm-hmm. If it's that 32% of the population is African American and infections are equally distributed, but 70% of the deaths are African American, then that suggests that the problem is somewhere else along the line. Either it's a healthcare access issue, or it's a quality of care issue, or it's a health behavior issue, but we'd have to figure out where that problem's occurring. But it's really important that we be very careful that these are not death rates that we're talking about. These are the proportion of the documented deaths. The other point I think that's really important is that it's also possible that there are deaths that are not in this database because people died and were not documented as being COVID deaths. So who did not go to a hospital, did not get diagnosed as a COVID death, who died at home, and then later during our autopsy, it was determined that they were COVID deaths. I don't know where we are in Louisiana with that, but this is another issue that we need to look at. So we're still early in this process. We still have more data to get. The health department is working on it, and I know that in time we'll have the answers we have. But it's very important that we not continue to say that these are death rates because it creates a misimpression.
Thank you for that clarification, Dr. Levis.
And sorry, I'm not.
No. I wrote that in my.
I'm not coming down on you, Earl. I'm just saying it because I just feel it as a task force. It's important that we don't go out and report out to people that that there's a 58% death rate among African Americans, but that really.
Okay, we have a
correct. That's not to say that there isn't a problem. I'm just saying that that's not the way we should.
Thank you, Dr. Levis. We have a couple of questions, and we'll take them in the following order. Dr. Riveras, followed by Raymond Jetson, followed by Dr. Keisha Davis. So, Dr. Riveras.
No, mine was simple. I just noted that the data didn't include Latinx numbers, and while certainly there may be members of those communities who don't report, I can't imagine a bunch of zeros for that.
Duly noted. I will bring that information back to the Office of Public Health.
And part of the question is I've looked at some data out of New York City where we're seeing 30% of the deaths are Latinx. The other point I'll make is I'm certainly concerned about the disparity for African Americans. I'm also concerned about disparities wherever they might occur. I don't see a lot of Latinx representation on this subcommittee or the task force.
Okay. Duly noted. Mr. Raymond Jetson.
My question was related to the outcomes that were identified. I noticed that one of them spoke specifically to providing best practices to healthcare professionals. And I was wondering if that was open for discussion at any point, because I was especially interested in whether or not that should include community members. Because after all, our health is not something that's owned only by professionals, but community members need to be aware of best practices also.
Mm-hmm.
Okay. And Dr. Dr. Keisha Davis.
Dr. Benjamin, you mentioned that the data set that you presented to us did not include the hospitalization data. Is work being done to partner with other portions of the Louisiana Department of Health and the Louisiana Hospital Association, where we are reporting that hospitalization data, although there are some limitations in the race element? Are we working to have that corrected?
We are in my discussions with the individuals that I met with regarding this data. We will be continuing to work through that. And so hopefully in the future, we can get some of that information or all of that information as we need it. So, but thank you for that. Yes.
Thank you.
Our next question is from Lisa Van Hoos.
Yes, so Dr. Davis just asked my first question, so I'll proceed to the second. What are the plans to collect data about COVID-19 related disability, the long-term issues associated with survivorship?
That's something I can bring back to the individuals that manage this data.
Awesome. And then also, would it be possible for us to get the race data cross-tabulated with the comorbidities?
Raise data cross, what did you say?
Cross-tabulated with the comorbidities. That would be helpful. Thank you so much for your presentation.
No problem. Thank you.
Okay, and we have a question from Dr. Amy Lesson. Her question is, I would urge us to pay close attention to socioeconomic status, income, in addition to race and other demographic variables.
Yeah, and I acknowledge that we may not always have access to that data. That's something we need to pay attention to. Thank you.
Thank you. Tina Granger. Her question, are the Louisiana coroners being required to test for COVID-19 on all deaths?
I don't know the answer to that, but I can put some fillers out.
Okay. Marguerite Escovery from Xavier. I work with Latino communities here, and we could easily set up a survey for this specific group.
Julie, what's that name again?
Margarita
we can send her
Escovery. We'll send you the
information.
She's a member of our sub.
Okay.
Dr. Peter Katzmartz. How are the data on comorbidities obtained for the mortality data? Is it by death certificates?
At the present, that's what they're doing. That and motor vehicles registration, I believe.
And his other statement was the data for obesity appears way off compared to other states.
Obesity? Oh, you're talking about this.
Yeah, obesity is one of the comorbidities which increases risk for mortality in this with COVID-19, and we have about a 40% obesity level, in the state. Yet these data are showing only 18% of these cases have obesity as an underlying condition. And data coming out of the hospitals in New Orleans are suggesting it's way different. It should be up around 60%, not 18%.
Duly noted.
Okay, from Dr. Maupy, can race, ethnicity data be captured by gender and age as well?
I will take it back to the managers.
And that we are seeing a significant prevalence among childbearing women of color.
Thank you.
Okay. Thank you so very much, Dr. Benjamin Robinson. You gave us a brief overview, and we know there are more questions to be asked, more data to be looked at, and we'll take these questions if you could and see if you can obtain the data for us.
Yes, ma'am.
Okay. At this time, I'd like to introduce my co-chair, Dr. Thomas Levis. He will provide us a presentation called The Skin You're In, and will give us an overview of a dashboard template using websites and social media from some work that he has done at Tulane. Dr. Levis?
Yes, thank you. Let me just get this started. So few weeks ago, well, early on in this the pandemic, it became clear that there was a lot of misinformation being circulated targeting African Americans in particular. You may recall that there was a widely held rumor that African Americans were somehow immune from being infected by SARS-2, and there were other myths that were circulating in the community as well. There's a lot of fear, at least I had a lot of fear, and a lot of others as well, that misinformation was impacting African Americans' behavior. And of course, health behavior is the primary strategy that we have at this point to get people to comply with behaving in ways that would reduce their risk. So if people are misinformed about what their risk is, and people are not trusting the information that they're receiving, or they're being given inaccurate information, this would lead to likely lead to increased. So I put a team together at Tulane to start working on putting together a health information campaign targeting African Americans. We've been working on it for about a week when I was approached about serving as co-chair of this task force. So one of the goals of the task force, was to do an information campaign like this, but we had already begun. And so what I wanted to do is show you where we are with the campaign, where we were planning to release this campaign starting on Monday of next week. And what I'm going to show you is kind of where we are at this point with portions of it, and make a specific ask, which is that we incorporate this campaign as the COVID-19 Louisiana Governor's Task Force on Health Equity, and that we would be an activity of the task force as opposed to just an activity of Tulane University. So the activity, the program is called The Skin You're In. The goals of the program is to do a social marketing campaign. We were targeting New Orleans, but also there was a national target as well, as we're using social media, which is of course national and international. But certainly, if the task force wanted to take this up and incorporate this into the work of the task force, we would not only rebrand this as being the task force's project, but then we would expand the scope beyond just New Orleans and make it a statewide campaign where we would focus on other communities throughout the state. So the goal was to target African Americans in New Orleans with accurate information, with the goal of helping African Americans to have information that would help them to make good choices in terms of health prevention, good choices in terms of becoming an advocate to others in the community with accurate information, fact-based information, with the goal of improving health, reducing risk for African Americans. The intervention is focusing on a culturally appropriate health information set of activities around prevention, about risk, and about providing people with resources that they can use to educate others. There's an electronic component. There's also an on-ground component, which incorporates using what we call street advertising or street marketing in the New Orleans area. So the campaign includes a website, television ads, radio ads. There's video blogs that we're producing. There's a blog. There would be ongoing webinars, podcasts, and there would be a print media as well, including local newspapers. Bus wraps, in other words, wrapping the public bus with campaign messages with accurate information, and a newsletter. And of course, there would also be social media, with the goal, of course, of decreasing the incidence rate of COVID-19 in African Americans, decreasing the mortality rate for African Americans, and ultimately strengthening the relationship between African Americans and our school, with the goal of the long-term goal of developing a health equity institute at Tulane that would have connections with African American community and build a relationship of trust. So I'm going to take you to the website. Now there's a placeholder website that is currently on our website, which is tsyi.org. But I'm going to show you the website that we're working on now that will be launched. Next week. This is the version that is not yet launched, but will be launched as of next week. So you see, it's very video heavy. Just scrolling down through it, just so you can see some of the things we're trying to cover here. And we added the logo for the Louisiana Task Force here. Of course, we have the opportunity to make other changes as well. Go to this page here. This page is just talking about the mission of the campaign and what we're doing. And here we would link to social media sites. Here, just some links to the Twitter and I think this is the Facebook site. We also have Instagram, which is here, and TikTok, which we are working on as well. Let's see. There's also articles which try to correct inaccurate information and put out accurate evidence-based information that relates to African Americans. We're working on a set of infographics that are downloadable. Again, the goal of trying to dispel myths and replace the myth with fact-based information. And then finally, I don't think we have the blog or the podcast is up. I would hope that we could have every member of this task force be a guest on the podcast as we start developing that, and also participate in the webinars that we would want to do. These are some videos that we produced for the campaign. This is actually Dr. Ron Blanton, who I recently hired as the chair of the Department of Tropical Medicine at our school. And he's demonstrating hand washing and hand sanitizing. And he's also working on a program targeting high school kids as well. So that's mostly what I wanted to show you at this point. We're asking people to talk about their own personal stories as well. And finally, there's another section that I just wanted to mention. If we haven't started it yet, but it's called People of the Pandemic. And this is kind of people doing video blogs about their experiences going through the pandemic. And there we're targeting, people who are in various walks of life. People that are homeless, people that have lost their job, people that are doing frontline work. Not only clinical work, but frontline work, working in the gig economy for Uber Eats or supermarkets, and people that are still out doing the work that is necessary for the rest of us to be able to work from home. Idea of the website and a lot of what, and the basic look of what we have at this point. Of course, it'll be optimized for various platforms. This is for computer. It's also optimized for an iPad and also for cell phone use as well. So that's the basic overview of it. I'm happy to answer any questions, but what we're looking for is the task force's, approval or agreement that we would take this platform that we've already begun, build on this platform, we rebrand it to be a product of the task force and become one of the deliverables of the task force. So I'll stop on that note and stop sharing my screen and take any questions that you have.
So are there any questions for
I have a
Dr.
question. This is
Levice?
Dr. Adair. How you doing? That was a great presentation. And I think that that the platform that you have is one that I think could easily be repurposed. We as African Americans need visuals, and we need things that are penetrating. My only issue that I will have, and it's not about what is at present, but is what as we go forward in the future. The problem I feel with a lot of the things that are done for African Americans, as far as media outreach, is that it's not good. And when I say good, it means that just because there are a bunch of Black people that put it together doesn't mean that it's going to be penetrating for the African American population, because there are a lot of African Americans that don't communicate well with the African American population. I mean, you know, it's one of those things that as a person in the media on the national level, as in a local level, I see commercials all the time where there's a group of people that have put something together that's supposed to resonate with the African American community, and it falls so flat that it just is a waste of money and time. So I think with the people at this table, especially Dr. Levice, and the folks that are at this on this committee and this task force, we have a lot of information that we could get out, and the people that need to be able to do it are people that have a presence in the community. You got Dr. Whitfield in Baton Rouge, you got Dr. Benjamin in Baton Rouge. We have so many people that actually are out there fighting the good fight. The messaging has to be, just because we all have PhDs and MAs and MDs and all that, that doesn't mean that we can communicate with African Americans to make this resonate. We have to make sure that it's the people that can touch the community need to be talking to the community. And that's my point.
Well, I certainly would agree with that. I mean, and that is, of course, the objective of the program, you know, and we would have, which includes the expertise on this committee, as well as expertise outside of this committee. One of the things that, I mean, I didn't even show you the social media sites, by the way. So just, this is the YouTube page that we've got, and some video content is there. Instagram, Facebook. We already have over 10,000 followers on Facebook. So I think we're resonating somewhat to have 10,000 followers in such a short period of time. We also have a friend, one of a good college friend, fraternity brother of mine is an executive in a music executive. He's a CEO of Disturbing the Peace Records, and he's offered to reach out to some of his artists and have them do some videos for us as well. So I'm very confident that we will produce content. Of course, we would also have access to the knowledge and expertise and skill set of you and others on this task force that would help to ensure that we do that.
Right. Thank you, Dr. Hebert. Your question was right on point. I think moving forward with this, not only is the message important, but the messenger. Mm-hmm. And so we have to make sure that our message, our campaign message, is coming from relatable sources, trustworthy sources, so that we can dispel the misperceptions that are out there and the destigmatization that I'm starting to see most recently, where individuals who have contracted COVID-19 don't even want to tell anybody that they have it. Like mm-hmm. it's a big cross on their chest, and that we can protect others who may come in contact with it, but they feel very stigmatized. I have a question here from the audience about can this website or platform be added to, expanded? And that is our thought, that we would take the fundamental premise of what Dr. Levice has here and expand it and tailor it and modify it with all the feedback, and just, you know, expand it into something that would be very usable statewide. So that was our premise of presenting this. We have another question. Can there be a push PSA to all cell phones within a certain zip code for hotspot areas?
That's a good idea. That's a good idea. I'm going to look into that. I don't recall discuss
We
that.
have a public service announcement.
Yeah.
Social media sites will certainly reach the younger generations, but what about older African Americans who may not use technology? How will we ensure that we are reaching them?
We also have a campaign that will be television ads, radio, newspaper, bus wraps. We're going to also wrap the bus stops, and also street billboards, advertising.
And another comment, remember our rural communities, some of which have limited or no access to broadband.
Yeah. So as I asked, as Dr. Brown and I were talking about this the other day, so as I said, the original campaign and what I showed you is still not even finished, but it was at that point, the vision was that it would be focused on New Orleans. So if we make this a statewide initiative, Dr. Brown and I talked about getting teams from other parts of the state that would be more knowledgeable about the specific nuances of those communities and how to reach people there. So we're talking about northern Louisiana, Baton Rouge, the Shreveport, the other parts of the state, that we could pull together teams that would be developing messaging, and it would coordinate with all of us together, but they would be providing messaging and strategies that would be more effective for those communities.
Right. We have a response from Theron Jackson. He says he hosts a radio show here in Shreveport, and he's hosting a virtual town hall meeting on Thursday of next week, and would love to include the voices and expertise of some of our task force.
Great.
So you can certainly reach out to him in that area. Ferdinand, my friend, I would suggest some urgency to this, since misinformation is a prominent factor for infections. So very true. Misinformation that has started and exploded over the past several weeks. And so certainly a section I believe you had, Dr. Levis, that said myths. We can do something about myths, misperceptions, or get the facts, something that can be tailored in that regard.
Absolutely.
Can we use this model and go into the community where we can get the furthest and most relatable reach, such as the churches? Partnering with churches.
Absolutely.
Okay. All right, I think we've covered, we have one more. How does the health and habits of African Americans in this state or country compare to other nationalities here in abroad?
Well, how does that, that's here abroad, meaning outside of the country?
I guess outside of...
outside of Louisiana. So, yeah. Well, so African Americans, we know these are broad generalizations, right? African Americans on average have worse health status than non-African Americans. Of course, that's not the case for every single condition or every part of the country. But on average, African Americans have worse health status, lower life expectancy than other racial and ethnic groups in the United States. Louisiana is one of the least healthy states in the country, as that was reported earlier. But just to be clear, that includes white Louisianans as well, who also have extremely high rates of the same chronic conditions that put you at increased risk of mortality if you're infected with COVID. When we compare, a few years ago, back in 2012, in the African diaspora, where I brought together researchers and health activists and advocates from 24 countries throughout the Western Hemisphere, and we all did presentations on the African descent populations of those countries, and then we actually edited a book on that. And I'd love to redo that conference in Louisiana, of course. And so we did get an idea of what's happening in some other countries, and it was quite a bit of variation. Overall, I would say that you do find worse health status among African descent populations in most other countries, Brazil being the country that's most analogous to the United States and where another country where a lot of research has been done. But then you do find some countries where the health status is not as bad as it is in the United States, or the disparities are not as great. And Canada would be an example of where we found African Americans there, or which is much closer to the health status of white Canadians. But if you look across most countries, Colombia, Honduras, Jamaica, Cuba, Brazil, they were all, Argentina, they were all represented at the conference, and we found disparities there as well.
And I just wanted to add really quickly that a lot of the comments that are coming in are addressing specific ways to get the messages out. And there are some great comments. We want to bring to everyone's attention that there is a subcommittee that has been or will be developed to specifically talk about the best practices to do community outreach, to do communications, to make sure that we're making an impact in those communities. So a lot of the things that you all are suggesting, those are suggestions that will certainly be flushed into subcommittees as well. So I just wanted to point that out.
Absolutely. And most of the comments have been very positive towards rebranding this sort of initiative using the format that Dr. LaVise has presented.
So if we agree to do this, I mean, I think what we could do is set up an editorial board comprised of task force members that would provide that ongoing input and feedback, you know, as we continue to develop the website, and not just the website, but the entire campaign. Website is only one part of it. And we would start working on making some changes to the branding to ensure that it's branded as a task force product. And I would like to still, because as Dr. Ferdinand pointed out, and launch the website as soon as it's ready, and we can continue to make updates and changes and, you know, rebrand it as necessary. But I do think it's important for us to get this information out and out to people as fast as we possibly can.
Certainly.
Certainly. So to redirect us back to our charge, what we have here, this messaging forum, is just one small component, one small deliverable of the task force. I think that will have a big impact, because one of the goals or outcomes is to provide reliable, data-driven information on COVID-19, particularly as it relates to safety and prevention. And so this would be one deliverable that would meet that goal. Okay, any other questions or comments for Dr. LaVise?
Anybody okay with moving forth to really further develop this work? I think we received some private comments that were saying, yes, go forth. Do I need to make a motion?
I don't think so. I think
I think everyone agrees.
All right, perfect.
Okay, great.
Wonderful.
Okay.
And we will be calling on certain members of the task force with certain levels of expertise. Thank you so much, Dr. LaVise. The next item on our agenda has to do with some COVID-19 task force committee priorities. What we did was solicit from our executive committee to submit to us some 3 priorities that they felt would be something that we could address immediately. This task force is going to prioritize looking at what we need to do short term. We may have some intermediate goals and then long-term goals. So short-term priorities, we were leaning towards testing, messaging, misperception, safety, prevention kind of campaign. Intermediate goals would be more of the ongoing education, repeating the message. by reliable, trustworthy sources. And then long-term priorities is where we would do a deep dive looking at access to high-quality medical care to improve our health outcomes and Louisiana healthcare rankings. We want to look at best practices from other states and see if those evidence-based practices will work here in Louisiana while still preserving our cultural nuances that make us who we are. So that's sort of our thinking. What's on the screen is the executive task force. We've not really taken a deep dive into it. Still needs to be narrowed. But if you can see, there are some commonalities. The first category has to look with collecting and analyzing the data. And Dr. Benjamin did a wonderful job in that. We've started that process. We're looking at mortality data. But basically, the task force is interested in looking at mortality data by race, long-term care facilities, geospatial, contact tracing efforts, looking at African Americans that have recovered from COVID-19 and certain variables as it relates to risk factors, professions, housing, transportations, social determinants of health. Others have recommended that we look at monthly, quarterly, annually, biannually community disparities and look at the data, create a Louisiana-specific health dashboard for citizens, organization, community use, increase community outreach and communications, targeting that educational campaign, develop a strategy to improve access to healthy foods, fresh fruits and vegetables in those food deserts, develop a plan to improve access to medical services and healthcare, using some type of mobile health assistance, mobile screening to bring healthcare to communities. Next slide. Can you go up?
Mm-hmm. Next page.
Identifying hospital bed shortage areas around the state, developing a mechanism to promote universal access to adequate PPEs, addressing allocation of appropriate resources as it relates to low-income families so that they can isolate safely who do not have adequate homes or who live in multi-generational homes. Focus on the incorporation of mobile testing, develop sanitation and disease prevention, a strategic plan for post-COVID-19 environment, examine ways to incorporate antibody testing that reduce cost, and then a couple of websites and reports, My Sidewalk, that we can look at. So this was generated quickly, turnaround with the task force, executive task force submitting these recommendations as priorities. As I stated, we still need to narrow the what can we do for the short term, intermediate term, and long term. Any feedback from the committee on what's been suggested?
This is Dr. Gee. Can you hear me okay?
Yes.
So
hello, Dr. Gee.
Hi, how's everybody? So I wanted to make sure, it was hard to digest all of this, but I want to make sure that a couple of key areas are included. I think one thing I'm very concerned about is as we go back to more normal, that there's this notion of an antibody test being a gold card or gold standard. And I want to make sure that we look at racial equity as we look at immunoprivilege and all of these issues around infection and who can work and who can't. I think there's an ethical component of this that really needs to be looked at in guidelines for employers. And as those guidelines are developed, that we really carefully consider how we return to work. So I think there's this whole piece about workplace protection, return to work policies, testing, and what is necessary for testing and who gets testing. I know you mentioned mobile testing, but I think it's also important to look at You know, I'm not really worried about people who work in corporate settings. I'm worried about people who work in bodegas and in mom and pop shops, you know, not getting what they need. And then I think, you know, you mentioned it, but making sure people who are exposed can self-isolate, whether that's through income supplementation or through using hotels or other vehicles. We've got to make sure people can self-isolate. And then I think we need to make sure that information is quickly disseminated. I think early on there were rumors that if you are Black, you can't get COVID, and they were very damaging in a lot of communities throughout this country. And we've got to be, next time there's something like this, we've got to be sources, and it has to be culturally competent. And so we've got to think about communication and how we're communicating. I mean, it was weeks after the epidemic started, the CDC had questionnaires that even I couldn't understand that asked me how many milliliters of sputum I had. I mean, we've got to be able to communicate with people, because people will die in these types of epidemics if they don't understand risk. So I do think those things need to be included. Thanks. I think this is a really good starting point.
Thank you. Thank you so much, Dr. Gee. Dr. Levis, do you have anything to add as far as what we've discussed with the priorities?
No, I think our plan was to try to pull together a list of priorities. And then once we have that list of priorities, we'll take another look at the subcommittees and restructure the subcommittees to opt what we put on our set of deliverables. So I think that's where we are now. We have, I think most of the task force members have responded, and maybe we'll give a few more days to get more input from the task force. And then once we've done that, that would put us in a position to be able to look at the subcommittees and figure out what's the right structure for the subcommittee and how we can organize ourselves to get the work done.
Can I say something quickly? In the groups that you're looking at, the newest hotspots are the prisons. Yes. And I think that certainly needs to be addressed on the front end so we can get good data on them. And a rich resource that exists that we participate on, we were doing daily briefings, but every Office of Public Health regional office has daily conferences that has the data that they're collecting on that you were showing earlier. They have it broken down by each region. And I don't know if the task force members, if they know the region and if that's happening, maybe Dr. Phillips can address that. But that has been a rich resource where all the parishes that are involved are reporting out. The coroners are on that call, the hospitals, the long-term care facilities, FQHCs, RHCs, everyone's on those meetings every morning. And best practices are shared in those meetings and hotspots and material. So it's another rich resource.
Would it be possible for us to have someone from the task force be on those calls to report back to the task force what's happening? And would it be possible for us to get access to that data?
Yeah, I think they're rolling it up, but yes, I'm sure that that'll be possible.
Right. One of the comments that just come through from Dr. Renando Banks, we need testing on weekends and evenings. That is certainly, Barrow, would you like to elaborate on our discussions about that?
Yes, and certainly we have been having those discussions, and there are a couple of things that are about to roll out, but they still are not, it's not enough in my opinion, especially, I'm just talking about the Baton Rouge region, but there are some plans, especially in working with Walmart to do more readily accessible testing. But I did want to go back to this as it relates to the timeline by which we are going to try to do the immediate and in the long-term goals. So do we have a timeline in terms of when we want to go ahead and start implementing or start kind of rolling some of this stuff out? I believe time is certainly of the essence, and I'm very concerned about what's happening in the prison system right now, especially the women's prison. The numbers are really, really very high.
And we have reached out for the data concerning the prisons. We know particularly about St. Gabriel that
yes.
had a surge. So that is certainly recognized as a hot spot.
Yes, yeah.
So our goal is to set those priorities short term, bring it back to the executive committees, and then move forward with our short term priorities.
Do we have a timeline for that for the short term? Are we talking about like a week, 2 weeks? I mean, what is that time frame, or have we not set that yet?
Dr. Levis, have we set the timeline yet for the campaign, the media campaign, the looking at the prisoners and nursing homes?
So for the media campaign, the timeline, I think we can have that so the social media site's already up. The website is not up. It's a placeholder website, but we can launch the new website on Monday. And I would propose that we do that, and then we can make edits and changes to it going forward. But that we go ahead and get it out there and get the information out in front of people as quickly as possible. Now, Dr. Brown and I had talked about writing a series of short reports. And when I say short, I'm talking 1-2 page reports, giving our findings and our thoughts on things that we could do, that we can recommend government do immediately. For example, testing, prisons. I was recently invited to visit the prison in Orleans Parish. And we can start doing little reports like that and making little 1-2 page reports with our suggestions of what we can be doing. So, for example, testing on the weekends and the evenings, we can do a 1 and 2 pager on that and put that out there as something that we think can be done right now. And what I think we should do is look for as many things that are happening in real time that we can impact right now. And then as we go forward, we can start looking back, maybe making comments on things that happened previously, and then looking forward to talking about what happens as we come out of the pandemic. But right now that we're still in the middle of the pandemic, my recommendation would be that we focus on things that are still happening that we can influence immediately. Mm-hmm. I think the prison is one. I think a brief commentary on the data, that there was a lot of questions about the data presentation and some suggestions on different ways that data could be presented, different ways that data could be collected. I think we have an opportunity, if we put out something, immediately, to maybe influence the health department's strategies around data collection. So I think there are things like that we can do, and some of that should be done immediately. We could do that in the next week.
The testing on weekends and evening is a priority that we have brought before the governor, and they are in an effort to do at least 140,000 tests per month is the goal.
Yeah. But who's doing the tests, and in what communities are those tests getting done, and who's eligible to get access to those tests? Those are the types of things.
Yes.
We have an opportunity.
That's my question. Who's doing it, and who's making a decision about what communities are prioritized? Is the task force going to get that state testing plan rollout to make sure that it's being done on an equitable basis using the data? Because that's not what we're seeing happening at present.
Right.
Well, that's why these regional meetings are so important. And the day you're going to have to get in the communities and see what the resources are. Dr. V, you might comment, because you have half the nursing homes that don't want to test at all, and then half that want to test everyone. And so they're sending some infectious disease folks in to give technical assistance to these nursing homes immediately to try to help them segregate, isolate, and have a strategy on how to mitigate. So you're right, it's varying from region to region, I guess. And I think if we can make a statement of best practices, because I agree with everything that was said. It was, the reaction has been not the greatest, and there's a lot that can be done, I think, immediately if we can get that.
And I think what we can do is draft something from the Health Equity Committee here to make a recommendation about extending the hours and having on weekends, especially for our African American communities and our frontline workers who cannot leave at 11 in the morning or 3 in the afternoon to go get tested. They cannot leave their jobs. So that's something that we can certainly address immediately.
What I would suggest as well is we do some level of assessment in terms of what's in every community. I think somebody may have alluded to that already, because you have our FQHCs who are actually doing testing, and they are doing it for extended hours. They are doing it on the weekends. A lot of people don't know about this resource in the community, but I think we need to do an assessment to find out what's happening in every community and see where the gaps are, and making sure that we are plugging in from those areas. Again, like I said, Walmart is getting ready to start doing some testing in our community. Those tests are being done at the hours that are most conducive for the people who need them.
And then the other issue is the plan. Once an individual tests positive and has to be quarantined, how do they quarantine in tight housing conditions? How do we safely quarantine multi-generational families living in one household once they have tested positive? So it's testing, tracing, and confinement if they're tested positive. And if they are, quarantined or confined, do they have the living arrangements to support that?
This is Terry Davis. I wanted to let you know that in North Louisiana, we are partnering with FQHCs in low-income areas in Shreveport and in our rural areas to send our mammography van out there with the swabbers, and they are working on the weekend also. Do a lot of the heavy lifting as far as the scheduling, and everybody's got to have a PCP now, and the FQHCs are providing that.
Right. So one of the priorities is making sure that we have the tests and the reagents, have the adequate numbers of tests to be able to go out and test. So those are some of the initiatives that we certainly need to address, of urgency.
So I have a question. So you talked about that there's going to be a ramping up of testing. Is there a written document that describes that testing plan? Does anyone know?
I think that they are following some sort of protocols. I can see if there is a written document somewhere, and I can get that.
So this is Kimberly Robinson, and thank you all for your submitted to the White House by the governor is for a monthly goal of 200,000 tests. And that plan is part of the state's reopening plan, where the governor talked about moving to phase 1 for reopening, and that goal lining up with the White House plan for reopening. It calls for 200,000 tests. There was a commitment this week from the federal government to roll out additional testing supplies and testing capacity across the country. So they have committed to providing the testing supplies that are necessary for those 200,000 tests in Louisiana. Those testing supplies will start coming in through FEMA and GOSEP and be distributed to the testing sites. Those testing sites will include the existing testing sites that are in place, but also moving testing sites to other places, the communities, to make testing available where it is needed. So what you've seen when we started testing was that the only place testing was the state health lab, because that was the only place authorized to conduct testing. We have since moved from that to commercial labs providing testing, as we were authorized to do so, and then partnering with FEMA to bring in the mobile testing sites that were approved. We've now moved those mobile testing sites from where they were originally to the impacted communities, such as the river parishes. We've moved them from one location in the river parishes to other locations, partnered with Walmart to have additional testing sites where needed, working with local governments and with the National Guard to provide the staffing at those testing sites, with the FQHCs, with LSU Health Community, and with colleges and universities to make those testing sites available. Yes, this has continued to evolve continuously since our first positive test on March 9th. One of the things we asked the Health Equity Task Force to do was help us in identifying additional places that we needed to be testing. Did we have testing everywhere that it was necessary? The plan for rolling out the 200,000 tests per month includes expanding that testing, expanding it to rural areas. The priority for testing had been hospitals and nursing homes. Expanding that testing to those persons who want testing beyond first responders and our medical community. We had always followed and were always required to follow CDC and FDA. Now that we are free of those restrictions, we will be expanding testing. The contract testing teams that are being built out by LDH, those plans are being developed into a document, and those teams will roll out. So that is something that we can share with the task force for your input. If there are places we are missing it, we have worked with local government officials to ask, where in your community do we need to expand testing? How can you assist us with expanding the hours that testing is available? And we are getting that feedback and making sure that we are doing that. But it is an evolving process. We did not start day one with having testing available all across the state in every community. We couldn't do that because, one, we were limited. Now that we have additional commercial partners and other places, now that we have testing supplies, including our universities that are 3D printing supplies, we have more capacity to continue testing and expand it. And we have the additional commitment of the necessary testing supplies, including reagent for testing for this month, since it is now May 1st. For the 200,000 tests we are planning as part of the next phase of reopening. So I think that kind of addresses where we are going forward. But if there are places that you know we need to expand testing, please provide that information so that we can include it in the plan that is being laid out. But that plan is being developed by the Office of Public Health with input from our
In terms of process, would it be better that we wait and see the plan and then react to it? Or do you want people to reach out to you with suggestions of locations?
I think if there are suggestions, for example, we have testing in just about every parish. Some of it is not as well known as people probably need to know, but there is testing in every parish and it alternates and it's at different hours, and the hours are set by the local officials on the ground who tell us these are the times that make sense. And so we get the feedback that this time doesn't work for anyone, yet we get an update from the guard who provides the staffing that we're open at that time because, or we're not open on this day because local government tells us there's no demand for it. So we've got testing stations that aren't open 5 days a week, for example, or 6 days a week, or even 7, because local government is telling us we don't need you open on Monday or we don't need you open on Tuesday. We're basing it on the feedback we're getting from those local officials. So if there's some things that members of the task force already know, you can provide that information, but Earl, Dr. Benjamin, and I will make sure that we get the latest version of the testing plan, if it is in a form that it can be submitted to the task force. Because I have not looked at the last version, at least not a version since or Tuesday before Dr. BU went to Washington. I think he's a little behind thanks to that Washington trip. But we can get that version. But if there are already people that, it sounds like there are some people that have some definite ideas of where we need additional testing. So if you can send that through the two chairs, Drs. Brown and Laviste, then we can work from there.
There are a lot of people that have written places inside the chat box, so just wanted to make that point. Ms. Robinson, per the sharing that you just—
Maybe Mr. Wilson can capture that for me. I'm not that technologically savvy to capture the chat, so I'm hoping that—
Yes, we
Mr.
are.
Wilson.
We
We're
have all
capturing it.
we have all of the questions in the chat.
Going back to what you shared, Ms. Robinson, and to Dr. Levise's point earlier, when he talked about the releasing of very short reports or papers, I think it's important, and I think testing was one of the first papers that I think most of us agree that needs to be done. But I think it's important, to your point regarding municipalities possibly saying, "Oh, we don't need this test at this time," and I don't know. We just don't know what's going on with that, that be one of the first reports that we do so that we can say, you know, as a task group, we think that it's important to do X, Y, and Z so that we are ensuring that individuals, particularly the most vulnerable individuals, are getting the test that they need. Because I would be interested to know what are the factors that go into determining when these municipalities. So I think a testing report that can be produced out of our task force as soon as possible would be of great benefit for the state, particularly where in those areas where, you know, we don't know enough about what testing is being done and how they're choosing to test, so that, you know, a statement is being made that testing is priority, and really that needs to be informed around the needs of the most vulnerable or the people that need it.
I just said,
And
Ms.
the
Taylor,
inconsistencies, there are some inconsistencies to the testing protocol. Some places require physician orders, some don't. So not only the testing plan, but what is the protocol for testing that needs some clarity?
I just sent Ms. Taylor the slide deck from the regional meetings that list all the resources in the region that we're in, Region 3. And I assume they're following the same template, but you see on there what I mentioned, all the parishes are represented. They list all the hospital beds and some more specific data. And then, but the point that was made earlier is absolutely correct. You know, we opened a site and had a good response, and then it didn't after a while. So you have to get input from the locals to know, you know, how to craft it to make sure you're getting the biggest response that you can. And those people in those communities that live and know the communities best will be able to give you the best information.
Dr. Brown,
This is
listen. One of the issues I have, and I heard the secretary talk just a few minutes ago about testing in places, that has a lot to do with geography. But the issues that I'm having, that I'm getting feedback on, is the fact that there are hotspots identified, which are communities that are largely African American communities, where this on a weekend of the people who get tested, and there are thousands of people who live in that particular community. When it's over, 140 people have been tested, and a significant amount of those 140 have come from somewhere else, not that particular community. And I guess my concern is whether or not in the data you're capturing is zip code a part of that data as well, so that we can really know, because one of the things that's happening, you know, it's almost shameful that if you get a community with 12,000 people contiguously in an African American community, we have a large one like that in our community. The mobile unit went there. They ended up with thousands of people, 140 people tested. And a significant number of those people had driven from other rural areas and whatnot to come and get the test done there. That may give you a check mark for your geography, but that does absolutely nothing to cure the issue that we have in those communities.
Right. So are we gathering zip code data, is that capture testing? Does anyone know? Secretary Robinson, is the zip code data captured with the testing?
I have not seen the
Yes, if
testing
not, then my
input
question is how we,
form, but I would assume that is because we do assign the location of the individual. So my assumption is that the zip code is captured because when you drill down into the map on the LDH website, you can see the number of positive cases by parish location, and you can drill down into neighborhoods on that site. So I would assume that we are capturing that. One of the things we want, so I'm hoping that we are now capturing all of that that is one of the requirements, but we may not be capturing that with the mobile testing. I think there are 193 total testing sites, at least what I'm looking at on our board. As of last week, there were 193 total testing sites. And this has not been updated, so I'm going to ask them where the updated list is of total testing sites. Not testing sites and labs processing tests. So we need to update that information, and I need to go find an intake form, but I suspect every testing site is probably using a slightly different form.
Mm-hmm. So Secretary Robinson, on that note of the 193, do you guys actually have the information as it relates to time, the procedure or process that's required as it relates to doctor orders, not needing doctor orders? Do y'all have all that information on your dashboard that you have there?
All of that is not listed on the dashboard.
Okay, I think that needs to be added. That needs to be something that we need to make sure we have.
Well, it's not on this dashboard that comes up on this screen. That's not to say it's not
What I'm seeing
in a database somewhere else.
Okay. If it is, I think we need to have that, because that's another issue, I think, as it relates in terms of people's ability to be able to get the test. Some places are requiring, some places are not, in a time frame by which, how much time people are having to spend doing that. I think is also another barrier. But I think that's one of the things we should have as part of the assignment.
So what we're hearing from the task force as a priority has to do with testing and messaging. That seems to be, from what we're hearing, a number one priority that can produce a short-term result. So there's some comments from the group asking about geomapping, or seeing a statewide master plan for testing, that would be helpful to see there, and looking at the barriers. We have physicians who've commented that they are facing barriers, having only one fax number to fax the doctor's order or the healthcare provider order, so it's delayed. So not only the process, but the coordination. We're hearing that there's some inconsistencies regards to who gets the testing and who gets the long inconsistency with based on sites where the individuals access testing. So there just seems to be some inconsistencies.
in addition to that, I think it's very important. And if we're saying that what we're going to be doing, our decisions and our strategies are going to be data driven, then there has to be some uniform or standardization in terms of data collection at these points of testing. And so that at the end of the day, we have data across the board, no matter where a person gets the test done. We get the same data and we'll be able to then be informed by the data. But once we start having holes in this data, we'll still be in a predicament because we won't know exactly, we cannot say definitively because our data itself is incomplete. So I think one of the priorities is to look at the whole data collection piece and what information are we getting and from which sector, so that would best be informed. I mean, I looked at Mississippi's data, and the case fatality for Blacks and whites is practically the same, but there are more Blacks who tested positive, and then so when you look at the percentage of Blacks who have died, it's high. It's about similar to where Louisiana is. So we need to have data that informs us so that we're not jumping the gun. I think Dr. Levis articulated that very early in this meeting. So I think we really need to look at the data, because at the end of the day, that's really going to be the ingredient that helps us make decisions and come up with strategies that work.
Can I just add one comment as well? As I agree with the comments that have been made already about the data, but just to remind everyone that all tests are not created equal, and we also should be assessing which testing platforms are being used across the state. There are inconsistencies with the sensitivity and the specificity of different types of tests, and I do grow concerned about some communities having tests with very false positive and or false negative rates, and being uninformed about that. So if we could also assess that as we're determining the testing going on across the state.
I'd like to address something about that as well. I'm really concerned about the testing that is being done for the antibody testing. We know that the FDA relaxed their guidelines and allowed a lot of testing to come in, and whether testing is truly for SARS-CoV-2 or generalized coronavirus is still theoretically up for debate. Even some of the tests that some of the big institutions in our city and state. So I'm really still concerned about that when we start talking about the testing. So Dr. Davis, I really agree with you that we have to decide on, even though our country won't come up with a standardized way to do all this testing, we should come up with a way that we're going to evaluate it and figure out how we, tweak it so that it makes sense for everybody. Because the Abbott test was a false negative rate for the not antibody, but for the actual virus. It was a 15% false negative rate out of the barn, straight out of the gate. So, we have to kind of look at some of these tests as well.
Okay.
So
Right.
that I think is going to help Dr. Brown and I in putting together the set of task force and deliverables. I mean, it seems like some things are just jumping out at us. Like there needs to be a group working on testing. There needs to be a group looking at data. There needs to be a group looking at communications. And so we'll work on that. And I guess that'll be our task for this next week, is to start putting together. We'll look at the task force, the subcommittee structure as it currently is. We'll look at restructuring those subcommittees to align with this conversation, and also to align with the priorities that we're pulling together. We'll have an updated list of subcommittees before next week's meeting.
Right.
Now, that you'd like to hear from, that you'd like us to invite to address this task force in future meetings.
Well, I'd like to say about the healthcare disparities that, we can look at the data, and one of the things I'm really concerned about is blaming the victim. That we're putting the burden on people unnecessarily and unfairly. We know that some of the healthcare disparities and the discrepancies, and especially in the African American community, are certainly responsibilities of individuals themselves, but others are responsibility of healthcare. And so, as some have said, access to testing, that's not on the individual. That's the delivery. disparate treatment of diabetes, that's not on the individual, that's on the healthcare provider. And so we've got to talk, that's something that I'd be concerned about. Beyond COVID, I want to talk about remedy those kinds of disparities and the ones that have been systemically placed upon people, especially people of color and especially people from low-income backgrounds.
Yes, Dr. Levis, this is Faye Grimsley. And I know we're talking about the data, and I think we would also like to consider looking at the data from all points of view so that the data is not used against any particular ethnic group or racial group for discrimination. And so maybe Dr. Lawrence or Larry Brown, I think you're familiar with him out of Baltimore, but I think he's now not in Baltimore anymore in that area. But I think he could shed some light on the different types of data and how we actually use different types of data.
He and I were on a panel this week, so I can reach out to him. And one of the things that he and I talked about was and I just wrote to the group about crisis standards of care, which were developed in 2009. And these are the standards that in a future event, if you were to have to decide which patient got event, they guide you as how to make that decision. And they're outdated and they have no comprehension of racial bias or how as we were just talking about, the fact that individuals of color may have more chronic conditions at no fault of their own because of life circumstances. And that all of this needs to be considered if you're choosing between one patient and another and who gets the vent. And so I think we need to dust those off and rewrite them. And we need to train up our clinicians so that if there's a next wave or another crisis like this, we have considered this and people have been thoughtful about it. So I don't know what the group thinks, but I think that would be an important thing to do because when we looked at them, they hadn't been updated since 2009.
The other CDC put together that actually can predict which communities are going to be at highest risk every time we have these pandemics. It's a tool that I think we have not fully embraced and used to our advantage because we know it's the next thing that's going to happen. So long term, I think that's something that that would be very useful.
Yeah, Rebecca, could you give me what was the name of the document you're referring to?
They're called Crisis Standards of Care. And we did a webinar with the National Academy of Medicine on them a couple weeks ago, but they're outdated. Louisiana adopted those standards, but they need to be rewritten. And fortunately, there was never a time when we had to use them, but New York did when they were at the peak. And so I think that we need to rewrite them. Mm-hmm. I'll send them to you, Tom, just so you have the most recent ones from Louisiana.
I had a question. This is Chris Tyson. So as one of the non-healthcare people on the call today, this is just overwhelming and incredibly impressive. And there's so many ideas. And I apologize in advance if I'm getting ahead of where the meeting is going. But it'd be great to understand the role of the subcommittees. I'm on a subcommittee. I imagine that many of these issues you're going to group into or assign to various subcommittees. And then we will take that work and kind of work towards a deliverable, or I just kind of want to know a little bit more about structure and process so that we can, and kind of what those next steps are. And again, apologies if I'm getting ahead of something.
No, you're right on target. The subcommittees were designed or developed based on subject matter expertise, and that's how it was categorized when your VITAs were submitted to us and you were recommended to serve on the subcommittee by the governor. And so at this point, with the conversations we've had and the data, we are going to look at setting priorities. Once those priorities are going to be set, we will have to look at possibly restructuring that. We may need someone from public policy, with someone from the medical community, with someone from data analytics, to work together on whatever is the deliverable that we want to achieve based on that priority. The priorities will drive the work of the committees, and we'll be determining who's best suited to work collectively on those specific priorities. We just wanted the whole group together today, as we will do periodically moving forward when there's relevant data that we want you all to hear. But driven by the priorities that we're going to determine.
Great, thank you.
We're also going to be reaching out to other states. Pennsylvania has a health disparity network or task force, so does Michigan. And so we want to form a network coalition with those states so that we don't work in isolation. We can learn from them, they can learn from us. We might be able to share resources. What we have learned is that Louisiana is not alone in these disparities. And so it would be helpful to know, how best practices are done in other states, or what other health equity disparities task force are doing. Again, this is unprecedented. There is no roadmap, which, we call us than us as far as Louisianians go. So we're in a unique opportunity to drive this, take the initiative, and determine what priorities we feel are relevant, and make recommendations directly to the governor.
I'll just follow up and say that I think some of the, and again, speaking from a policy viewpoint, some of the, what we got out of this conversation and what's in the comments is really exciting, and looking forward to hearing more about what opportunities there are. I think Dr. Gee has talked about executive orders in here, just what other kind of follow-up channels or implementation channels there are, particularly with regarding policy. Looking forward to hearing more about that. Thanks.
Thank you. Well, are there any other comments, feedback, recommendations that you would like to discuss at this time?
Dr. Brown, I know it didn't. I didn't see it in our in the task necessarily of this task force, but just as a citizen of the state, it appears to me that we find ourselves now. 2 weeks ago, headlines being that African Americans were being disproportionately impacted by this. Here we are 10 days to 2 weeks later, and the headlines are reopening the economy and the state and so on and so forth, almost dismissively. Let me just say, this is my opinion. I guess what I'm concerned then about is whether or not the people who are working, let's say there's a Resilient Louisiana Commission or something like that, that's about opening up business and otherwise, are they being informed by groups like this to say, here is this checklist? Are we working in two vacuums, separate and apart from each other, not informing necessarily each other of the work that's being done? Because I think, and I put in the chat some things that we ought to ask questions about. Is disease transmission under control while we're ready to go back to work? Are health systems able to adequately detect, test, isolate, and trace every contact? I mean, where are we? And since that's maybe not their wheelhouse, could they look to a group to say we're at 12%, we're at 60%, because they appear to be moving on their own emotional intelligence and not necessarily by the science and the data that so many of you who are in this group could provide for them. And as a member of the community, I'm concerned about what's driving the decision-making process of our government. And if, in fact, the legislature is ready to storm back into the Capitol, certainly no disrespect to those legislators, but I mean, what are they going to be informed by, politics or science? And I really think that there's got to be some question. And if this group exists, as much data as we can present as soon as possible, I think maybe I'm being utopian when I'm hoping that it will inform the decision-making process. But I do think at least there ought to be something they have to look at and ignore.
Thank you, Mr. Jackson. As a matter of fact, Dr. Levice and I had conversations about this week, that we want to, and we would have to ask Secretary Kimberly Robinson, that there should be some representation or some integration of the task force, the resilience Louisiana Task Force, we think should hear the voice of this Health Equity Task Force as they move forward with their decision making. So we're definitely going to ask if we can be engaged in that process, have some dialogue, and see exactly what the plans are and how it's going to impact
Dr. Brown,
our vulnerable population.
just to try to provide some feedback to, I think, Reverend Jackson, I believe. Those discussions are being had, and the decisions that are being made are based, the governor is following public health perspective in making those decisions. And so I have been a part of a few of those conversations. And so people are being very, very intentional in moving things forward and not doing things so hastily like other states are doing or have been doing. And so I hear you in that. And there are many people who are working inside LDH that are also thinking from that perspective. And so we're making very thoughtful and strategic decisions in moving forward to reopening Louisiana. It's no decision is just being made by those who are public health minded and who are concerned about all Louisianans, and in particular, conversations are being had about those who are disproportionately affected by it. So I just wanted to take the time to say that those conversations are being had, and the disparities that have helped to push this group into existence are part of those conversations. And so just wanted to share that.
Well, that's good.
Well, I just hope that while that group feels their charge to reopen Louisiana, that we feel our charge to be to reimagine Louisiana.
Mm-hmm.
Yes, sir. Yes, sir.
Dr. Jackson, thank you very much. Let me just tell you that group's charge is actually to imagine a resilient Louisiana. Their task is not to reopen Louisiana. That is the Louisiana is also to reimagine a resilient Louisiana. It is not a charge to imagine a reopened Louisiana. Now, they have been tasked in the task force level, which are like your subcommittees, with industry-specific guidance on best practices for reopening. And they have been implemented to include public health professionals. Dr. Laviste is one of the public health professionals advising the gaming task force on whether what they are proposing takes into consideration what is considered a best practice or would be amenable to ensuring the public health aspects of their plans allow for social distancing and the protection of those persons who would be going into those establishments. Every task force has a public adhere to those things laid out in the White House plans for reopening America, which requires that there be 14 days of decreasing symptoms, and that it continues in that you meet certain gating criteria, that you have increased testing, that you have contact tracing, that you have hospitals that can handle the capacity, that all of those things are in place. Not that we are opening the state or opening business without any consideration to those things. So there is nothing about the governor's plan that does not take all of those into consideration, and no plan of the task force would be implemented that includes any recommendation that does not follow CDC guidelines or factor in all of those and included in any task force recommendation that would be coming forth, including a review by the Secretary of Health and her recommendations on who the public health professionals are that would participate in each of those task force.
Thank you, Secretary Robinson.
You are welcome. And
All
just
right.
FYI, the crossover is me between both task force. Or both
I was going to
commissions.
add that actually.
That's great.
Right. So we will make sure that the committees are talking to one another.
Yeah.
Yeah.
We talk.
Yeah.
Thank you.
Thank you,
so much.
Secretary Robinson. And thank you to all of you for chiming in. Obviously, we have a very impressive cadre of leaders on this call today. People who are obviously very committed to this work, committed to making a better Louisiana. Very good question of next steps. We're going to be sharing the information that was discussed today. We've also gotten some presentations and informational resources that we'll be emailing to each of you. We're going to continue reviewing the comments and working through each of those. The co-chairs will get those shortly. We're also going to, again, continue working through the prioritization of those short-term, intermediary, and those long-term goals. We will also be sending out information on the next meetings. For the executive committee, we actually have a meeting next Friday. So we'll be sending you some information. Also, you'll get some information on the different subcommittees. As you know, we're going to go back, look at those, and then we're going to send some information out to everyone. And there will be a platform for you guys to provide any input that you would like at that time. When we want to thank Dr. Phillips. We also want to thank Dr. Wilson from the governor's office. On behalf of Ray Belton, we appreciate you all engaging in this work. Dr. Kim Hunter-Reid, Board of Regents, all of our Louisiana universities. We are also pulling together any information that was submitted through the public comments so that those also can be answered as well. Anything that you all need, please feel free to reach out to us. But again, you will be receiving via email lots of information from today's meeting. So we want to thank you all again. Are there any more questions to come before this committee? We are about 4 minutes shy of 4 o'clock. All right, hearing none, we will go ahead and adjourn the committee. We hope that you all have a wonderful weekend and look forward to all of the many emails that we're getting ready to start sending. Y'all have a great weekend. Thank you.
Thank you.
Thank you.